Welcome to our town hall for February 25th. My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs. Happy to play a moderating role today for our Q&A and part of our celebrations. And to kick things off, we have a good agenda today, as per usual. I'm going to start by asking our President and CEO, Rob McIsaac, to let us know what we'll be hearing about today. So Rob, over to you.
Okay, thank you very much, Aaron, and good morning, everyone. As always, thanks for your time that you're taking out of your busy days to participate in our session today. As usual, we have a full agenda, and the team will cover off what's happening in our hospitals, what's happening in the community, some projections about the virus and modeling and next steps around vaccine distribution, including vaccination for healthcare workers and the start of getting vaccine into the arms of community members, in particular those who are over the age of 80. New outbreaks at Juravinski Hospital this week and a slow but steady increase in variants of concern are sober reminders that we are still in the midst of this pandemic. And while there's been some positive signals from the government regarding vaccine, now is not the time to let our guard down. I think it's worth mentioning that while there appears to have been good news around the vaccine supply coming out from the federal government, the fact of the matter is we have not seen significant increases in supply locally. So vaccine will remain a scarce resource for some time, although we're trying very hard to make sure that we get our hospital workers done as soon as possible. We need to remain vigilant and abide by all safety measures while at work and in the community, just because of where we continue to be at in all of this. On another note, I want to acknowledge the progress that we're continuing to make on important transformation initiatives that will set us up for the future. This week, many of us were part of a series of meetings to kick off the work to design our new hospital information system. Project Odyssey is one of the largest clinical and quality improvement projects that we'll ever undertake as an organization. I know that it's a challenge to take this on in the middle of the current circumstances. So I want to really say thank you to all who have shared their expertise so far. I know that your energy is required on a number of different fronts, and you continually rise to the occasion. I think it's important to say, just to give a little bit of context to this project, as large as it is, as daunting as it is, we're not the only ones, even in the GTA, who are implementing an Epic installation at this time. We are really almost lockstep with UHN, who is doing just the same thing. So I think the project has so many patient safety, experience, quality benefits that it's important for us to continue to move that project forward. I want to assure you, nonetheless, that we are closely monitoring operations and capacity to manage COVID while we proceed with Project Odyssey and other work necessary to strengthen our organization for the future. And we will continue to balance that against the realities of what staff are facing on a day-to-day basis. As always, my profound gratitude to everyone at HHS for being here for our patients, our community, and each other. I'm extraordinarily proud of all that's been accomplished and all that continues to be accomplished despite some very challenging circumstances. So a profound thank you. With that, I'm going to turn it back over to Aaron, who I think is going to be conducting a brief survey of the people in attendance here today.
Yeah, thanks very much, Rob. We wanted to try today to trial run the polling feature within Zoom to see if we could use it for different things as we host these town halls. I think it's a great way to get feedback. It's also, at least today anyways, a nice way to try and determine who's attending the town halls. So we're going to launch a polling feature. I think most people should be able to. For those that are maybe on a mobile device or dialing in by phone, this may not be as easy for you. There's two questions, so you scroll up and down, 1 and 2. The first one is to identify your role at Hamilton Health Sciences, just choosing really what applies best to you, recognizing some people have more than one role in these categories. Additionally, if you scroll down, you'll see the second question is about what you might consider your home base for Hamilton Health Sciences across our organization. Again, recognizing some people might today be at a different location, might have accountabilities at multiple sites, or might even be working from home because you're in an administrative position or otherwise. So just again, choosing what you think most appropriately applies to you in this questioning, and we'll let it go a little bit longer, maybe to the minute mark, and then we'll just see. So today, I think it gives us a nice barometer on who's on the line and who is tuning in for the town halls. We can usually assess by looking at everybody's email addresses, but it's not always known exactly what roles are there and what's going on. So I see one saying the submit is not working. So we'll see. Again, this is a trial run today to see what are the challenges for different ones of our participants in using this function. So here we can see already the results should be available for those on the line. You can see that we have a balance, I think, of clinical and administrative representation, senior leadership in attendance as well. We do have a high degree, about a third of our participation from our Hamilton General Hospital campus, as well balanced representation across other sites, King West, Juravinski, Mumsey, St. Peter's, and West Lincoln, all proportional, I think, to the size of the workforce that you would consider for each of those sites. So thank you. Thanks for indulging us in that brief moment today. Again, we're going to consider how we can use this feature to engage the audience as well. So if you have any ideas, you can certainly punt that feedback to the hhsnews@hhsc.ca inbox. We'll have that email address up later. So thanks very much. And now I'm going to hand things over to Sharon Pearson, our EVP of Clinical Operations and Chief Operating Officer, to give us an update on where we're at in our pandemic response and otherwise. So Sharon, over to you.
Great, thank you very much, Aaron, and good morning, everyone. And my update is very much like my previous in terms of how we're doing across our sites. Our number of COVID patients is down somewhat substantially from where it has been. And Dominic will talk about those trends. In looking this morning, I think we're actually sitting at 30 patients, so just slightly below that 32. And speaking to St. Joe's, their numbers are just slightly lower than ours. Rob referenced the outbreaks in his opening remarks. We had peaked at 6 outbreaks. We're down to 2, again, at the Juravinski site. And none of us are anticipating we'll stay outbreak free for some time. Certainly, we're very happy to be below that 6 mark. But we do anticipate that until we get our vaccinations complete and more work done on the COVID, we're going to unfortunately have to deal with these outbreaks. As far as the operations at the sites, it really does look like most of our other Februaries look like in terms of our admits to no beds. Our occupancies rates are high across all of our sites. We have pressures with ALC. The volumes are up. Our surgical volumes are almost at our pre-COVID numbers now, a little bit behind in cardiac surgery, but otherwise at that 100% mark. So again, pressured hospital system that we are all very much used to in October. In terms of all of the conditions regarding COVID, the provincial directives, the regional directives regarding the 15% capacity that we are to maintain, that surge capacity, those still remain in place. We must do that. We must still continue to participate in the census balancing that has been going on now for upwards of a month, I think. And again, we updated the numbers on the slide so you can see what the impact has been in our region. And we also must continue to support our congregate partners. We have seen a decline in the number of outbreaks. I reported that last week, and we continue to see that this week. We do see new pressures in our shelter system, though. And as far as Grace Villa goes, again, we reported last week that all of our staff, our frontline staff, had returned. We do maintain a management presence at Grace Villa, and we are working on a transition plan now. So there's a sustainable model for Grace Villa. And if we could just go to the next slide. I did want to highlight one of the innovations, and it was highlighted on the Hub this week, and it is in the Spectator if anyone gets a chance to look at it. So COVID has certainly brought out the cliche, you know, all of the challenges we could never want, but it has also brought a lot of innovation forward. And so this urgent care model, really a tripartite effort with St. Joseph's, with Hamilton Health Sciences, and with London Health Sciences to introduce a virtual care model that targets adults, children, and seniors. It's a wonderful, really exemplar of innovative work that can happen in a very compressed period of time. It's actually work that I think many clinicians would say we would have taken previously years to put in place, and it was done in very, very compressed timelines with the help of Ted Scott and many others. HHS's contribution really is around the LTC Cares model. We have talked about LTC Cares at these forums previously, but really it's a support for the congregate settings whereby they can reach out, talk to an ED physician around issues with their residents. An assessment can be made if the resident needs to come to hospital. But if not, there's support available to them as far as diagnostics and treatments and redirection for other specialist care. So it is a wonderful model. It's been in place for a bit of time now because we had been piloting the model, and response has been overwhelmingly positive from the residents and primary care physicians. So more work will happen to expand each of those programs. And I would acknowledge Dr. Michelle Welsford and Dr. Mohammed Panju for their medical leadership on the LTC Cares model. So please read the Spectator article or have a look at the link on the Hub or in the deck. And I will hand it back to Erin, and happy to take questions later.
Thanks very much, Sharon. Yeah, that was a nice to read this morning for sure. Next up, I'm going to ask Dr. Dominic Mertz, our medical director of infection prevention and control, to give us an update on the epidemiology for the pandemic, which is always an insightful presentation to have. So Dominic, over to you. Where are we at?
Yeah, thanks, Aaron. I would say in a similar spot as last week, but certainly less positive news than I started to get used to report back on a weekly basis since our peak early January. So again, let's start with the Canadian picture here, sitting at on average 54 per 100,000 per week. So that's quite stable compared to last week. We see BC currently increasing at 69 with a RT value of 1.12. We see Nunavut with 71 being quite high, and we see Newfoundland, Labrador still struggling with their B117 outbreak as well, currently sitting at 47, close to where we are at still in Ontario at about 50, and our RT value just around 1. So relatively stable, but certainly not falling any further. Next slide. And that's what you basically see here. That's our provincial view, the epi curve with the peak early January. And then we had that nice decline into the 50 per 100,000 per week range. And that's where we are currently sitting at and continue to sit with, if anything, number of cases now starting to slowly increase again. Next slide. That translates into what you see in the hospital as well. the decline that we have had has plateaued as well in a range of 700 to 800 admitted patients, which is similar to what we had beginning of December. And that's certainly a concerning piece when you're thinking about when we came into the second wave, we started at a much lower or much better hospital capacity from that perspective than if we are thinking going into a third wave with the current number of COVID patients already admitted. Next slide. Hamilton, similar picture as for the province. We had a week that was clearly better. Currently, we are sitting at 55. I have the line here at 50. So again, pretty much same as last week. We had a few days that were significantly worse. We had other days that were better. We typically have around 40 to 50 new cases per day currently. So ranging in that 50 to 60 per 100,000 per week range. So pretty much where the province on average sits as well. For us, that's comparable to end of October. Next slide. This is the community cases per 100,000 per week. So again, taking off those outbreak cases, which we use to guide our policies. Again, you see that plateau here, things being somewhere in that range of 10 to 15 per 100,000 per week. We have our line at 20, but as you know, as I said previously, we are not planning to make any policy changes in terms of relaxations, given the variants of concerns, the reopening of the society at this point of time, and wait and see how that third wave will evolve. Next slide. Hospital admissions, again, similar picture as with the province. We reached a plateau, and as Sharon mentioned, we are looking at somewhere between 40 and 50 hospital people admitted within the city of Hamilton with COVID currently. The ICU proportion still being relatively high, as you can see at the bottom, with the second black line and those dark red bars there. So almost half of the patients that we have, or close to half, actually in the ICU. Next slide. Okay, talking about that third wave, I think it's less of a question if or whether we will see an increase in cases again. The question is how significant that will be. This is the modeling from a couple of weeks ago. There will be new modeling coming out later today. But what you can basically see is that so far we pretty much followed that dotted line, which would be a continuation of a 5% decrease. Now you saw the RT value around 1, so certainly no longer there. As I mentioned, it's more of a plateau or numbers slowly starting to go up again. The question will be, will it be a big third wave, or will it be more of a wavelet, which is the term that people like to use as well? And for everyone who asked, what will be the impact of B117 for us? I keep saying there's an awful lot of uncertainty. We know from several countries that you can control B117, but again, it may need significant public health measures. And it doesn't look like we will be moving down from red to orange anytime soon. The more likely change at some point will be to be back in lockdown for a few weeks. At least that's the predictions at this point of time. Will not be this week, next week, or in a couple of weeks, but well possible that this may occur to mid-March to end of March. Next slide. This is the famous federal modeling with this brutal third wave as a plausible option when lifting public health measures, or if only the current public health measures would be maintained, which is this gray line. The good news here is, on the next slide, I added in a tiny red line that you see, next slide here, yeah, it's hard to see, where we are currently sitting at the national level, and in fact, cases nationally still trend downwards. So we are currently neither in that orange nor in that gray scenario. Whether we will be following the blue scenario or not needs to be proven. I would expect us to be somewhere between that gray and blue scenario eventually. Next slide. Then those VOCs, so the variants of concerns, public health now has this in their daily reports, where you would see that the percentage positive for variants of concern, that's just the screening step, we are sitting somewhere between 15 and 20% in the province at this point of time of all the positives. And you can also see how this increased since beginning of February, where we were more sitting at the 5% range. So that's that expected increase in variants of concerns as it's being observed in other countries around the globe. Hamilton is currently sitting at 4.9%. Now, keep in mind that this can change very quickly. You need one large outbreak with the B117, and suddenly your proportion will increase very significantly. We haven't had any in Hamilton yet. That's why we are sitting still where the province was sitting at the beginning of February. Yeah, that's everything from my end at this point of time. Happy to take questions afterwards, and handing back to Aaron.
Thanks very much, Dr. Mertz. Thanks for the update. Always good for you to put what we're seeing and hearing in perspective. Next up, we have Leslie Gauthier, our Vice President of Clinical Support Services and Surgery, to give us an update on the ongoing work around our vaccination push. Leslie, I know that continues to fill the news media these days, and I know there's so many people working extra diligently in the background on the planning. So can you give us some insight about what's happening right now?
Good morning, happy to do so. So to build on Rob's and Aaron's comments, the planning for vaccination in Hamilton is really a partnership with Public Health, Hamilton Health Sciences, and our colleagues at St. Joe's. Today's update is really just building on the information we shared last week. So the fixed clinic on Wellington has reopened, and second doses are being completed for about 600 or 6,000 of our healthcare workers between HHS and St. Joe's. So the intent is whoever had first doses will be completed within the next day or so, depending on some personal scheduling. Everyone who's had first doses is being administered their second dose within the range of 35 to 42 days. So we're following provincial guidelines and the information that is available from Pfizer. The good news is that the plans within the next couple of days is that we're going to restart the administration of first doses. And those people who will be getting called are in that highest sequencing group. These are our teams most at risk of contacting COVID in the majority of the work that they do every day. So people should have had calls coming to them from the scheduling teams within the vaccination clinics. The work that's happened in the last week is the province published a revised sequencing guidelines. It was not a lot of change. Our highest risk group still remains very consistent. There will be a direct message out for our laboratory teams who are doing COVID testing. They're now included in the highest risk group. And then we've worked with St. Joe's, and we will publish a revised, and it's not big revision again, but the sequencing framework. So people will be able to see the province has the highest risk group, then a very high group, and then a high priority group and a moderate group. You'll see that new framework. We're not asking anyone to do anything different. If you've already registered, we're going to do that behind the scenes. And then if I can go to the next slide, please, just some reminders for people that in terms of our patients across HHS and St. Joe's, our ALC patients and our satellite health facility patients, a sweep has happened to vaccinate those patients. It obviously won't account for anybody newly designated in the last couple of days, but we're working on a plan to maintain the vaccination of patients in hospital who are designated ALC. And then the plan is to complete the patients at St. Peter's by the end of this week. From the city perspective, our long-term care homes and high-risk retirement homes we shared last week, again, the majority of these clients have all received first doses and a lot of them their second doses. So there has been a fair amount of attention in the media in terms of the public health rollout that the next highest community group is really going to be targeted from a client perspective on those who are over the age of 80. Right now, public health is planning that rollout for sometime in March, potentially towards the end of March, but there will be communication out around those people living in the community, not in long-term care retirement homes, to be vaccinated. So just a couple reminders on behalf of the vaccination team at HHS is when you are speaking with the actual staff in the clinic, this team is not the right people to be giving personal individual medical advice, whether or not you should or shouldn't receive a vaccine, or around if you have questions around some symptoms you might have following. We really are encouraging people to reach out to your own personal physicians or health team to give you personal advice. And lastly, I always need to wear my PPE task force hat and to remind people being vaccinated is great and awesome, but we are reminding everyone that we cannot let down in terms of our very basics of wearing PPE, really good hand hygiene, and maintaining distancing from wherever possible. So with that, I'm going to hand it back over to Aaron. Thank you.
Thanks very much, Leslie, and to all our presenters. So we do have an opportunity to do Q&A. Just a reminder to everyone on our town hall today that you can always check out the hub and other the COVID resources available online as well on the HHS website to know exactly what the most up-to-date FAQs are. Of course, always happy to answer questions here too, either live or in writing. So there's two ways you can ask a question. You can type it in the Q&A function. Please try and use the Q&A function for questions. We'll save the chat forum for our celebrations in a moment. You can also raise your hand as a participant, and we'll call on you to ask your question live, should you wish. So two ways for you to raise a question. So here we have a question about the recently announced pandemic self-isolation pay. Around the matter of costs, for sure this safety initiative was an important thing to do, but does have a cost that's hard to scale. You know, in the context of the pandemic, Rob, I don't know if you wanted to comment a bit about the ongoing discussions with government. I know we're incurring many costs. The sector is, in fact, and there isn't a lot of cost certainty. What have you heard from government in this regard?
Yeah, you know, there is certainly a COVID account, and there will be an ultimate reckoning with what is being submitted through the COVID account. So I think we're taking a prudent and conservative approach to the expenses that are being remitted under that. So I have a reasonable degree of confidence that we won't have any huge surprises. There's a couple things in the question that I think should be addressed. First of all, the question asserts that we are continually operating in deficits. That's simply not true. We do not operate in deficits. So I want everybody to know that we balance our budget every year, and that's a very challenging thing to do, but we do it. This is not a cost that is so large that we would have to develop a specific strategy around. So without dragging everybody into the arcane process of developing hospital budgets, we will develop an understanding of what our pressures will be for the next year and try to develop strategies for that big bucket instead of, you know, on a case-by-case basis. I think the last thing I'd say around this is that, look, We did this for many reasons. Deciding to cover sick pay. Probably the most intuitive is that it was the right thing to do from our perspective, but beyond that, there would have been a cost to not taking this decision. And so, this was one of the reasons why we decided to move forward with doing this. I do think it's something that's been, I understand, has been reasonably well received, which I'm very happy to hear.
Thanks for that. And I just want to point out, I know Dave McKeag and Michelle LaRue are both on the line. We fortunately didn't have them added as panelists, so you couldn't see the question that was asked. So I apologize. But maybe, I don't know if Dave or Michelle, you just wanted to add comments generally about the pandemic self-isolation or anything that Rob has put forward.
I can jump in. Sure. Can you hear me okay, Aaron?
Yeah, for sure.
Oh, perfect. So yeah, I mean, Rob covered it very well, actually. There's been, as you can imagine, dozens of implications, financial and otherwise, for our staff as we've gone through this pandemic. And each decision that we've taken, we always try to take for the best interest of all. And from a financial perspective, there's lots of challenges and uncertainty from the pandemic itself. There's a lot of very excellent work in the background around tracking, understanding, conversation with government, with Ontario Hospital Association around how it will all flush out. So it's a bit of controlled chaos in one sense because of all that goes on, but we have very good line of sight and understanding of our numbers, the implications, and are raising all the appropriate issues. So feel as much as any, and we talk with our peers, we understand our position, we understand how others are treating issues as well, and we're very confident that we're doing good work and we understand where we're at. And beyond that, I really wouldn't have anything to add to what Rob said.
Thanks very much, Dave. Okay, Leslie Gauthier, I have a list of vaccination related questions here. Some process, some Bruce may want to get it on too. We'll see as we go, but certainly the first one is around the, what's the time frame during the day or evening that one might expect to get a call from the vaccination team? Is there a typical time frame for those calls being made?
So actually, the plan is that they would be called between like working in the day, 8 in the morning and upwards towards 9 p.m. at night. Bruce, I don't know if you want to provide any more specifics. I think it's been variable to the number of people we have available to be making the calls.
Yeah, that's correct, Les. Sorry, I can't get my video on, Aaron, but yeah, calls will be placed right through into the evening, as late as Les says, into 9 o'clock.
That's great. Your picture looks great, Bruce. It's always everybody.
He's on now.
And now you're stuck with what I really look like, but there you go.
Their hair's growing in and they're all bearded and pandemic looking. So anyways, next question up is about how we're tracking our staff vaccination status and what impact that will have on units that are in outbreak. I guess the presumption there being that there could be a positive prevention impact in those units, or anyways, could you comment at all on that?
Yeah, so I saw the question in the chat. We absolutely hope that all of our staff and physicians volunteer to receive the vaccine, but again, it is voluntary, it's not mandated, and it remains personal health information. So we really don't have a mechanism now to say to a manager of the ICU how many of staff, physicians, or learners on their team have been vaccinated. All vaccinations are reported through to the province in a database, but we do not have it at the unit level. So whether or not vaccination becomes a decision in outbreak, I'm going to suggest that's no different than when we're managing H1N1 and we had conversations around vaccinated staff. It will become an HR conversation.
Gotcha. Okay. Thank you for that. Next question is around, I know, so I guess maybe I could just, first of all, how does the rollout take into account community healthcare workers? So to the extent that you can comment on the broader push out into that realm, what role is the fixed clinic playing, et cetera?
Yeah, so really good question. So if you look at the link to the provincial framework, just like there is the highest priority, very high priority, high and moderate. One side of the chart is for the hospital worker, and there also is included in that a community partner in each category. So we will start to see, as we finish the highest group, there will be first responders from the community who are also going to be vaccinated at the same time. So we're still working through the details of beyond the highest group, how the teams will integrate and where people might be vaccinated in the city of Hamilton. But absolutely at that city table, we're looking at both hospital and community as we go forward with the vaccination plan.
And I think similar question is coming up here about the mode of communication to the people over 80 in the population in the community, which is news today. Like what does that look like when we're thinking about that population and how to reach them and make sure everybody's aware?
Yeah, maybe I'll comment on that one, Aaron. Honestly, we're still working that out at the city table, exactly the mechanism to reach out to the 80+ population. And so I'd suggest that, when that's worked out, there'll be a communication coming out. There are logistical challenges. Honestly, the province has had some struggles in developing and rolling out the tool. And we heard the general talk about this in the media yesterday. And so local public health units, including this one, working in partnership with us and primary care and other stakeholders are looking at, okay, well, what are the mechanisms that we should explore and implement, and when? So for more to come, no answer yet, really.
Understood. Thanks for that clarity. Leslie, I know we've talked in the past on this town hall about the ALC patients, vaccinations for those that are going to LTC settings. Here are the questions specifically about those being discharged to a retirement home. Is there a plan to vaccinate HHS patients who are going to be discharged to a retirement home? Could you comment on that at all in relation to those other issues?
I'm going to play hot potato with Bruce again. I think our direction has been patients going to long-term care at this time, but Bruce?
Yeah, so the system is still working to be able to respond quickly to those patients expecting transfer, Aaron, and we've run into challenges because as Les has spoken to previously, vaccine doses come in vials, and we want to ensure that we optimize those. So the plan is to be able to do those with as much timeliness as possible, but we're not yet at a place where it happens for every single person making their way into a congregate setting.
Gotcha. Okay. You guys can have a break for a minute. Next question up isn't about vaccination, but there might be another. Next question up is about addressing what is happening at the Wellington parking lot of HGH. I know this week we did temporarily move 100 people that park in that lot, or 100 spots to the Barton lot. I know the province has asked us to conduct an assessment in that lot, so it was deemed an appropriate thing to safely move people out. I don't know, Kelly Campbell, maybe you can shed some light on that announcement in particular. I know we really don't have much more information than that, though.
No, we don't, Aaron. And I think the good news is that we did have capacity in our Barton lot, which is just right across the street, for about 100 staff to move over. So there has been a communication from the VA parking services to those staff impacted. We are maintaining access for patients and visitors coming to both Ron Joyce and the rehab building. So that has not been impacted. But yes, unfortunately, there's not a whole lot more information we can provide at this time, other than alerting staff to, as of Friday, their parking access will change to the Barton lot.
Okay, thanks very much for that. Question here, maybe Dr. Mertz, this might be one that you can shed some light on. How it's about the sequencing for the variants of concern, or any variant, I guess. How often are we sequencing COVID positive tests to determine whether it's a variant of concern or a new variant at all?
So the current process is that every positive gets screened for mutations that would identify them as a potential variant of concern. And all of those that screen positive will undergo sequencing. The first result of the screening is now being rolled out at our own lab, and we should get that information roughly within a day of the positive test. So we typically wait less than 24 hours for the test result, and if that test is positive, we should get the initial screening result within another 24 hours. Sequencing takes a couple of weeks currently. We will start sequencing in our own lab as well. So it's one of the labs in the province that will be doing the sequencing, but that's not up and running yet. And for now, for the centralized sequencing, it takes several, or at least a couple of weeks, I would say. We are still waiting for many sequencing results of patients that we currently have in the system that tested positive or had that initial screening positive for potentially a variant of concern. Given our current epidemiology we have, the assumption is that pretty much all of those that screen positive for variants of concerns will be B.1.1.7s, so the UK variant.
Understood. There's also a couple of questions raising the issue of the amount of time between first and second dose for certain vaccines. I know the news media has been talking about perhaps the duration. Potentially, it's okay that it's longer than anticipated, et cetera. Can you comment at all on what the prevailing scientific logic is around the distance between doses, et cetera?
Yeah, I think we had this question repeatedly here, in particular a few weeks back when we suddenly had that shortage in supply and had to delay the second doses. Taking one step back, the reason why we have a magic 3 or 4 weeks is that's how the vaccines had been studied. It doesn't mean that that's the best way they would function, but that's how they got studied. So typically we try to do exactly the same as a drug was studied. The evidence that we have from other vaccines and from some small studies along the way now with COVID vaccines as well, is that if there's a difference at all that's clinically significant, we may actually see better immune response rather than an inferior immune response if there's a delay. But probably 1 or 2 weeks delay will not make a difference into either direction. So we still don't know much more than previously, but certainly I haven't seen any evidence that would suggest that someone would be worse off if we waited 6 weeks rather than 3 weeks in a particular case.
I see. Certainly an evolving area of understanding for sure. Leslie, I have a couple questions here about process for alert for vaccination appointments. One in particular about if you miss a call, is there a callback option or a text option, or how does, I mean, that could be nerve-wracking for someone realizing they've missed that call. What should someone do in that situation?
So the most important message right now is the calls are still coming as no caller ID, the majority of them. So is to pay attention to your phones for that no caller ID. We are trying to work on a vaccine clinic line that will come up to read vaccine clinic, but that's still work in progress and not yet landed. I appreciate there's many people who may not be able to grab the phone call or will miss it. The way the system works, if you don't answer the phone, your name is just back into the randomizer to pull your name again. So there really isn't a callback. There's, as we've said, thousands of people being scheduled, and it's a completely random system as to who we pull from each sequence group. So solution trying to be worked on to identify the clinic on your phone. Currently not, it's still no caller ID. And if you miss the call, your name is back into the randomizer and you'll get called again.
Understood.
I'm watching Bruce nod his head. I got it right.
Okay, confirmed. There are as well a couple of questions here addressing in a similar way, sort of the notion, I know you've talked about this, but it's an important topic here, it would seem, is how many people in the highest priority group are still remaining, and how do we know? Can you talk a bit about that?
Yeah, so I mean, I kind of just looked at the numbers this morning, and we are very close to completing the highest group. In the next category, there's about 4,000 people to be done from the hospital side. And as I said, we're still working with the community to understand the community side of that equation. If I can skip to one other question, Aaron, just to draw a theme that I saw in the chat line. People are asking about those who used to be in sequence 4. So the majority of the old sequence 4 are not forward-facing staff physicians. That group now pretty well moves into the moderate category. And yes, you still will be vaccinated. The plan is still to vaccinate our healthcare workers through the 293 clinic. We just have to work in sequence with provincial and city direction until we get to that last category.
Okay, there's also questions about the grouping of priority 2 and 3. I think that's come up in a couple of questions. Is how can you place that in the context of the answer you just gave?
Yeah, sure. So the old sequence 1 is the highest priority group, which are those people who are directly working with high COVID risk every day, ED, ICU, the COVID unit. New into that category is the laboratory staff who are doing COVID testing. The second group and the third group, the old 2 and 3, are now merged into this highest priority or very high priority group. They're merged together. And essentially that group is now any of our teams that are forward facing, providing direct patient care, either inpatients or ambulatories. So it's basically anyone else who is forward facing, involved in patient care. The last category is those people really important to our work, but are not doing direct patient care or are working remotely. So 2 and 3 merged into the new category of very high priority.
Gotcha. And that's all automatic for those that would have assigned themselves in the previous categories. They've been reassigned.
Absolutely. Behind the scenes, the 2s and 3s are getting merged into the new group. There will be communication coming out from St. Joe's and HHS, which will give you the link to sign up. When you link, if you go forward to signing up, you'll be signing up to the new categories. So new ones follow new, old ones we're going to take care of.
Okay, very good. Well, I know we are at 20 minutes past the hour. We aim to wrap at half past the hour. I want to leave time for our celebrations portion. I know there's still questions in the Q&A, and some of them are related to vaccination as well as other topics. Just rest assured, there's a few ways that we will clean up the remaining questions and get responses to people. One is to respond directly. Second is to post additional and new questions to the FAQs, or frequently asked questions Q&A, or question and answer documents that are posted in the COVID-19 resources on the website, and as well other places on the hub. And then we'll also try to address these questions, anything that's remaining in the presentation at our next town hall a week from now. So Rob, I think in terms of our celebrations, maybe you and I could take a look at what's come up. A reminder to everybody that's participating, you can give a shout out or recognize a colleague or some accomplishment or good work in the organization by shouting out live. If you raise your hand in the participants forum, we'll call on you. Or you can type something in the chat forum and Rob or I'll read it out for everyone today.
Yeah, Aaron, maybe I'll start out by drilling down a little bit into some of my comments off the top and just give a shout out to Barry Lum, Michelle Leaflor, and the rest of the team working on our Odyssey project and the great work that they're doing. And you know, it's so incredibly exciting from my perspective, the difference this will make for both our people and our patients.
Great stuff. I see here shout out from Kim Alvarado. Shout out to Louise Brady, Nick Miller, Dave Morrison, and the bioengineering team for implementing the new remote patient telemetry monitoring system at the Juravinski Hospital and Cancer Center in record time. Nice to hear. So thanks for that, Kim, and congratulations to that team on that hard work.
Another one there, excuse me, from Derek Bailey. Aaron, want to recognize our screeners who are doing a wonderful job, often dealing with persons who are anxious attending our facilities. Yeah, great shout out and great work by our screeners in what can be a job that requires great diplomacy and tact.
For sure. I see one here from Ted Scott, from Ted saying, huge thanks to the general internal medicine team and all that are involved in the COVID model of care, providing innovative remote patient monitoring. Thanks for drawing attention to that, Ted.
Really nice shout out from Kim Alvarado. High five to the manager and staff at Wendy's who arranged for a crew of staff while they were closed to prepare a cheeseburger for a patient who requested this as a final meal. Very heartwarming to see this level of community support.
Yeah, that's what a nice story. That's wonderful. Cool. Something here from Yolanda to everyone. A shout out to the teams involved in vaccinating all St. Peter's Hospital patients. Some nice stuff. I see Bruce. Bruce has his hand up.
Thanks very much.
You're on camera there, but I didn't know if you wanted to jump in. Then I saw the hand, and it was on.
I should wait my turn. I just wanted to give a shout out to the leadership team and the team in eating disorders, who many of you would have heard over the weekend on CBC's White Coat Black Art, really talking about the national crisis in terms of access to eating disorders and the challenges for those patients during the pandemic, and the exemplary work that our team is doing to reach out to those kids and their families.
Yeah, thanks for pointing that out. That's great stuff. Thanks, Bruce. Nice attention for that issue on CBC. I see one here. Rob, do you want to read the one from Amber Walton?
Sure. So from Amber, a shout out to the administrative staff and leadership team, Odyssey, for arranging the workflow walkthrough sessions this week. That's very tricky, putting those two words in there. I can't even imagine how much work that took, and they're going great. So thanks, Amber, especially for putting in workflow walkthrough.
At least you didn't put really wonderful workflow walkthroughs. Say that 5 times. Here I see one from Patrice Cloutier thanks to Ron. Oh, this is from Christy McKenzie. Thanks to Ron Lowe and the team for quickly responding to a flood in the early hours yesterday morning, impacting the F1 pathology lab and breast assessment center at the Juravinski Hospital and Cancer Center. So thanks to that team for the middle of the night or early morning response. Tough stuff.
Yeah, another one from Catherine. Thanks to our housekeeping staff who came to the aid of the JH after the flood on Monday. So yeah, same, really great recognition.
And now here's a real one from Patrice. I think he was pasting something earlier, but a shout out to all those who worked over the past few months to prepare our T4s. It's tax time. Thanks for pointing that out, Patrice.
Yes, that's the most wonderful time of the year.
Kelly, I see you've come on camera. Did you have a shout out to make?
I did. I just wanted to thank our colleagues at the Volunteer Association Parking Services at the general site, Elizabeth Quetchen in particular and her team. Obviously, they had to pivot pretty quickly to move 100 staff from one parking lot to another, deal with staff sort of concerns and questions and issues, and they always do it very professionally and in great collaborative partners. So I just wanted to shout out a thank you to Elizabeth in particular.
Great. Well, Rob, I think we'll draw it to a close there. If you wanted to give some final remarks, see you next time.
Yeah, thanks, Aaron, and thanks everybody for coming today. Hopefully you found it helpful. To the extent that we weren't able to answer perhaps with perfect clarity all your questions, I just want to give you my strong assurance that we are trying very hard to get answers to your questions. So we will continue to do so, whether it be around the parking lot or around the vaccine. I know I was a little bit dour about the circumstances concerning vaccine supply. I mean, the fact is we could use a lot more supply in Hamilton. There's no two ways about that. But having said that, I think it is a nice sign that we are moving on to the next group of first dose employees at Hamilton Health Sciences and St. Joe's in the next few days, in the coming days. that's a bright spot for us, and hopefully we can get through the remaining patient-facing staff as soon as possible. So anyway, just wish everybody a great rest of the day. It does look like a very pretty day out there, and maybe just a hint of spring in the air. So that's a great sign. Anyway, thanks all. Have a nice day and a great rest of the week.